Greeting, folks. In this video, we are going to discuss the difference between the extubation in the emergency department versus intensive care unit. So, there is paucity of literature on ED extubation. Scott Weingart and colleagues examined the safety of the extubation in a cohort of 50 ED trauma patients cared for highly specialized ED with ICU nurse patient ratio of 1:2 or 1:3 and run by trauma and critical care specialists experienced in the extubation. Selected patients were intoxicated, had no significant injury after initial trauma was complete. After initial trauma workup was completed, or had any injuries that required temporary deep sedation only. Okay, so in carefully selected patients, they found ED extubation was safe with no unplanned reintubations. Okay, 16% of their patients were discharged from the ED. An application of this and similar extubation studies from the ICU or a post-anesthetic care unit should be applied with caution or general ED setting. ED extubation is safe and feasible provided that certain unit logistic and patient features are met. Close monitoring after extubation is the biggest obstacle to ED extubation. Clinical environment must provide intensive monitoring by clinicians and nurses. Okay, so clinical environment must provide intensive monitoring by clinicians and nurses who can recognize and manage extubation failure and reintubate if necessary. Continuous pulse oximetry, telemetry, blood pressure monitoring are a minimum. End-tidal carbon dioxide monitoring is not a standard practice but may be helpful in determining the presence of apnea, airway obstruction, hypoventilation, or hypercapnia. Dedicated staff, that is 1:1 or 1:2 nurse to patient ratio, must continuously monitor newly extubated patient. Okay, so because similar to recovering a patient from procedural sedation, there is a debate in extubation literature regarding acceptable and reintubation or extubation failure rates. Extubation failure is associated with significant morbidity and mortality, or even after correcting for the underlying disease process that leads to extubation failure. ED patients are early in their disease process. If there is a question or a concern about extubation readiness and whether a particular disease process is resolved, then patients should be extubated in a traditional ICU setting. Patients with a low risk of reintubation should be selected. Okay, so excluding elective reintubations, an ED unit should have a goal of near zero rate of reintubation. Patients should be monitored closely for appropriate amount of time after extubation based on existing evidence. 1 hour should be the minimum duration for ICU monitoring, intensive monitoring, and the specific patient characteristics should also be considered after an ED extubation. Uh, Patients with cardiac or lung disease may need to be observed for longer than 1 hour in a monitor setting. Further evidence is needed to determine optimal length of monitoring of their EDX.